All right, good morning. We are going to be covering lesson 7 today, which is disorders of breathing. So, talking about the respiratory system, the overall goal of the respiratory system is going to be primarily to maintain oxygen and carbon dioxide within normal limits. Um, kind of three or four important processes that go on with this. One is alveolar ventilation, that is essentially the movement or the exchanges of gases down at the alveoli. Pulmonary perfusion, which is going to be the actual circulation to the lungs that picks up and transports the exchanged gases. And then making sure that we are matching our ventilation and our perfusion kind of pressures in order to achieve optimal gas transfer and gas exchange. So let's talk a little bit about the underlying physiology of the lungs. Very simply, as we all know from our prior nursing school, we have our upper and our lower airway, essentially dividing at the neck from the larynx down. So when we talk about upper respiratory infections, we're essentially saying neck up, and when we say lower respiratory infections, we are essentially saying neck down. Trachea, if we do a cross section of it, is essentially a kind of a cartilage type tube with little cartilage rings that help to keep it open and keep it from collapsing. Your esophagus is a similar tube, but it has no cartilage rings in it, and therefore it tends to lie flat most of the time. The trachea, obviously, we want it open at all times, and so these kind of little cartilage rings provide a little bit of additional support. As you can see, there's a lot of other structures in and around supporting that. You have connective tissue sheaths, you have the epithelium, etc., as well as kind of some lymph type tissue and vessels going through. The lower airway, the most important thing to recognize is that there are 5 lobes in the lungs. So we have, on the right side, we actually have 3 lobes, and then on the left side, we have 2 lobes. So the right side has the upper and the lower, as well as the middle lobe, whereas the left side does not have a middle lobe. The other thing that's important to recognize is that we have 2 pleural layers. So if you look up here, you'll notice that there's actually a little bit of a space in between our pleural layers. And this is the area that provides a little bit of kind of lubricant and cushioning so that when your lungs are moving and they're breathing, that they are not rubbing against the inner and the outer surface. You've actually got a tiny bit of fluid right there that helps to kind of cushion that. This is also the space that when we talk about things like pneumothorax or pleural effusion, that this space, this pleural space in between the outer lining of the lung and then the lining of the rib cage itself is what will fill with fluid or air. The diaphragm is the next really important structure associated with the lungs. The diaphragm inserts on the lower 6 ribs beneath the sternum and kind of right around the area of the 3rd lumbar vertebrae. It is innervated, meaning that there's nerves coming into the diaphragm, specifically the phrenic nerve. And this is a very important nerve because it is responsible for the movement of the diaphragm. And if you paralyze the phrenic nerve, you actually are not going to be able to breathe normally. Phrenic nerve irritation is also what is classically responsible for diaphragmatic hiccups. So if you're hiccuping, essentially the nerve is transmitting impulses abnormally and causing abnormal contractions of the diaphragm. The diaphragm itself can only work if it is properly stabilized, meaning that it's attached to the intercostal muscles along the rib cage and the abdominal muscles. And it has a tendency to be a little bit more uncoordinated at birth, which is why you see kind of those abnormal movements sometimes with babies where it looks like their belly is moving peculiarly when they're breathing and sleeping. The other thing that's kind of interesting about the neonate, the newborn, is that they have a lower proportion of kind of fatigue-resistant muscle fibers in their diaphragm, which means that they are actually more prone to diaphragmatic fatigue. So if there's increased work of breathing, this is why children in particular can run into trouble because their diaphragm will actually fatigue and they will go into respiratory failure. When the diaphragm moves, essentially what's happening is that the muscle of the diaphragm that are attaching to the diaphragm is moving up and down. So it's actually pushing upwards in order to push air out. And then as the diaphragm itself moves down, it is going to be drawing air into the lungs. And that is essentially how respiration is happening. So we're creating this negative pressure vacuum-like system where as we pull down on the diaphragm, we're increasing the negative pressure within the lungs, and we are drawing air inside of the lungs. And as we push back up, we're increasing positive pressure, and we are pushing air back out. The alveoli themselves are specifically the site of where all the gas exchange is going to be happening. So while you're moving air down through your trachea and down through your bronchi and into the bronchioles, those are really just the passageways. You're not exchanging any air there. All of your gas exchange is actually going to be occurring in these small grape-like clusters called the alveoli down at the very, very ends of the lungs. The alveoli are what are affected when we have pneumonia. So if these little guys get filled up with mucus or they become inflamed, then we're going to start altering our ability for gas exchange and gas transfer. You have millions of these little alveoli at the ends of your lungs, and the air comes in, and these are very thin-walled little items that allow gas to kind of just simply diffuse back and forth across the membrane of the alveoli into the little capillaries that are kind of touching and surrounding the alveoli, and the gas is just moving back and forth freely using concentration gradients. So the next thing we're going to talk about is neurologic control of breathing. So when we talk about breathing, there are really two types of breathing. We have what is called voluntary breathing, and we have involuntary breathing. So you can choose to take a breath and you can choose to hold your breath. Voluntary breathing, the thing that's important to recognize about that is that it can always be overridden by your involuntary pathways. So you can be trying to hold your breath until you pass out, but the point at which you pass out, you're going to resume involuntary breathing. Voluntary breathing itself is controlled via the ascending pathway in your kind of respiratory control center. So cerebral cortex to the spinal cord to the diaphragm. And there are three nerves that are involved with this. This is your phrenic nerve, your vagus nerve, and your posterior thoracic nerve. Next to each of these nerves is listed the kind of nervous system that these are specifically associated with. So you can see that the phrenic nerve and the vagus nerve are associated with the autonomic nervous system and are responsible essentially for control of the diaphragm, the larynx, and the pharynx. And then the posterior thoracic nerve is responsible for control of the intercostal muscles, and all of these work together to control voluntary breathing. Involuntary breathing is a little bit more complex in that there is essentially a central neural control center. There's actually several of them that work together. And then there's peripheral chemoreceptors, so chemical receptors out in your body that help to sense carbon dioxide, oxygen, and hydrogen. And when we say hydrogen, we're generally always talking about pH. So it's sensing the pH of your blood. How acidic and how basic is it based upon how much hydrogen is present. And then the last component that works with this is what's called our lung reflexes, or our stretch receptors. And these are called inflation reflexes and deflation reflexes. So you actually have reflexes that tell you when to breathe in and when to breathe out. So you reach a certain point where you stretch, you breathe in, stretch, 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 and then it triggers the exhalation or the deflation following that. So you can see that this little picture on the right-hand side is showing your brain, which is your central neurologic control, and how it is coming down to the medulla oblongata and the pons, which are sending out nerves down to the chemoreceptors and our lung reflexes and our stretch receptors. So the two primary areas of the brain which are responsible for neural control are the medulla oblongata and the pons. The respiratory center of the brain essentially needs to match the rate of ventilation to the metabolic demand in your body. As metabolic demand in your body goes up, more oxygen is needed in order to generate your metabolic processes. Specifically, we can't make ATP if we don't have oxygen. So as we have greater energy demand, we're going to need to bring more oxygen in, and we're going to have more carbon dioxide as a waste product that we need to get rid of. along with those hydrogen ions, which are used in ATP production. So really what the central respiratory centers are doing is they're matching how fast do we need to breathe in order to get oxygen in and carbon dioxide out in order to maintain our metabolism at the rate it's going. This requires that we have not only proper nerve conduction pathways, but that they be properly myelated. And myelin is essentially, if you think of it like a sheath that is around your electrical cord. It helps to improve the transmission of electricity down that electrical cord and prevents the electricity from kind of fizzling out, stopping, or going into other areas. If your nerve cells are not properly myelinated, you're not going to be transmitting impulses correctly, and therefore you're not going to be able to respond to the commands from the respiratory center because the impulses are never going to reach the intended areas. Or the essentially the sensors that are out in the peripheral are never going to be able to send the proper stimulus back up to the brain. So anything that interferes with our nerve cells or our synaptic potentials or the propagation of impulses can disrupt our respiratory patterns. So again, involuntary control of breathing, medulla oblongata, this is responsible essentially for initiating breathing, and we call this ventral and dorsal. So ventral is our expiratory breathing, dorsal is our inspiratory breathing. The medulla oblongata is also responsible for non-respiratory movements such as coughing, sneezing, vomiting, and swallowing. Beneath the just above the medulla oblongata is the pons, which is controlling the rate and the intensity of our respiration. So these are both kind of working together. And the pons has two centers within it called the apneustic and the pneumotaxic centers. So the apneustic center essentially is promoting respiration, and the pneumotaxic is doing exactly the opposite. It is inhibiting respiration. So when our apneustic center is working, is it going to increase the intensity of our breathing? It is going to increase the tidal volume, the quantity of air that we breathe in because we're trying to breathe in more. And it's going to be it's going to be inhibited by stretch receptors. So if you breathe in too much, you're going to start to stretch and it's going to say, whoop, stop. And then also inhibited by the pneumotaxic center, which is inhibiting respiration. Pneumotaxic center is essentially controlling your fine respirations. It's going to decrease the amount of air you breathe in, which is your tidal volume. And it is going to be inhibited by the phrenic nerve and obviously the apneustic center. This picture here shows us the kind of those four combined centers, both in the pons and the medulla oblongata. And up near the top we see the pneumotaxic center, and beneath it the apneustic center, which are the pons essentially. And beneath that is the medulla oblongata, which contains our ventral and dorsal centers. Below that is the spinal cord, which is now going to be then transmitting those impulses back, transmitting and receiving impulses from the chemoreceptors and our stretch receptors. So let's talk a little bit about chemoreceptors. Chemoreceptors are very important for our breathing, and there are two different types. There's our central chemoreceptors and there's our peripheral receptors. This is very important, and this will be something that you'll want to understand the difference between. Central receptors, the thing that's very different about them from peripheral is that they can actually desensitize over time. So central receptors sense hydrogen in the cerebral spinal fluid as pH, and they sense carbon dioxide concentration. This is your primary method of telling how much you need to breathe. So if your hydrogen starts to climb in your cerebral spinal fluid, then your body's going to say, oh my gosh, pH is going up. It's going to note that you have additional carbon dioxide there, and it's going to say, hey, we need to increase the rate of respiration in order to get rid of this additional carbon dioxide and to bring the pH of the blood back into normal range. So this is your primary method. So most of us who don't have any type of lung disease, we are increasing our breathing at the point that our body recognizes that we have too much carbon dioxide in our blood, and the point at which our pH starts to shift. The secondary kind of fallback method is called peripheral, and these chemoreceptors do not desensitize over time, but they predominantly rely on oxygen in the aortic notch and the carotid artery to tell you whether your oxygen levels are falling too low. So they use carbon dioxide, but not quite as efficiently. So they're kind of the primary method for the peripheral receptors is actually oxygen and then also pH. The reason this becomes important is for people like your chronic obstructive pulmonary disease patients who are walking around with chronically elevated levels of carbon dioxide. When you have chronically elevated levels of carbon dioxide, you can't keep breathing faster all the time because you're going to fatigue and you're going to burn out your respiratory system. So what happens is that these patients start to tolerate a slightly higher level of carbon dioxide in the blood, and they shift to using the peripheral chemoreceptors to keep their breathing going, which means that they're strictly relying on the oxygen levels in their blood in order to tell them when to breathe. This matters because if you have a patient with chronic obstructive pulmonary disease who's coming in and they're struggling to breathe, and you think, gosh, their oxygen's a little bit low, let's go ahead and give them a bunch of oxygen and bring them up to 100%. The problem is that when you do that, you're actually shutting off their secondary mechanism that's telling them to keep breathing, and you can shut down their breathing. So when their oxygen level rises, their brain says, oh, hey, we must have enough oxygen here, so we don't need to breathe as much. So over-oxygenating your COPD patients can actually suppress respirations because otherwise because they're no longer using their central chemoreceptors, they're relying strictly on their peripheral chemoreceptors. So the little equation down at the bottom is just showing you how as carbon dioxide rises, this means that bicarbonate is increasing and that the pH of your blood is going down. You are becoming more acidic. This triggers your chemoreceptors and results in a change in respiration. So on this side, we show acidosis and alkalosis. So essentially what we're talking about when we're talking about pH and hydrogen ions is acidosis and alkalosis. And this can be either respiratory in origin or it can be metabolic in origin. We're not going to be getting as much into the metabolic origins of acidosis and alkalosis here, but you've all heard of diabetic ketoacidosis and lactic acidosis, which are metabolic versions. For metabolic alkalosis, things like vomiting where you're throwing off, you're getting rid of additional acid are going to send you into alkalosis. From a respiratory standpoint, respiratory acidosis is caused by things like asthma. So you are not getting as much air in and out. Therefore, you're not able to get rid of your carbon dioxide, and you're building up higher levels of carbon dioxide in your blood, and you're becoming progressively more acidic. This is also going to be true for pneumonia and for hypoventilation. So respiratory acidosis is essentially any sort of a state that results in hypoventilation. You are not moving gases as effectively. Your body is continuing to engage in its metabolic processes, which means it's dumping out carbon dioxide, but you can't get rid of it because you're not ventilating properly at the lungs. Therefore, you're going to build up carbon dioxide and hydrogen, you're going to increase your bicarb, and you're going to become progressively more acidotic. Respiratory alkalosis is anything that results in hyperventilation. You are breathing too quickly, you're throwing off too much carbon dioxide, and therefore you have less bicarbonate in the blood and you become progressively alkaline. So this could be anything with hyperventilation, a panic attack, aspirin poisoning, something that increases your respiratory rate. The little arrows that we're looking at here are showing which direction your pH is going versus which direction your carbon dioxide is going. And you'll notice that every time the CO2 goes up, your pH is always going in the opposite direction. When we talk about acidosis or alkalosis being compensated, what we're doing is we're saying that the body uses bicarb here as a buffer. And if your carbon dioxide is going up, it's going to try and increase the bicarbonate in your blood to kind of get rid of a little bit of that carbon dioxide in order to try and balance your pH. So when somebody is uncompensated with respiratory alkalosis, their pH will go down because their carbon dioxide has gone up, and their bicarbonate will not have changed because they haven't done anything about it. When they start to partially compensate, the same situation is happening. Basically, we have a rise in carbon dioxide in the blood, resulting in a decrease in pH, so they're still going to be acidotic. But we're going to start to see an increase in bicarbonate as the body attempts to compensate using metabolic approaches to kind of take away some of that acid from the blood. When someone is fully compensated in respiratory acidosis, their pH will be within normal range, even though their carbon dioxide is higher, and their bicarbonate will be higher in order to compensate for it. On the opposite end, we have respiratory alkalosis. Again, when it's uncompensated, the carbon dioxide is going to go down because we're blowing off too much carbon dioxide. We're hyperventilating. That means that our pH is going to go up. We become alkalotic, and we haven't compensated, so our bicarb levels have not changed. Partially compensated is the carbon dioxide goes down, pH is up, and our bicarb levels go down because we're starting to compensate. And by the time we're fully compensated, our pH has neutralized, even though our carbon dioxide levels are low, and our bicarbonate levels are proportionately low in order to balance this out. This slide is just a graphic representation that shows the effects on pH and ventilation when you hyperventilate versus when you hypoventilate. So it's just simply a restatement, but also showing that this is a bit of a negative feedback loop. So when you hypoventilate, you're going to be increasing the pressure of carbon dioxide in your blood, which means an increase in hydrogen ions, which are then going to affect your chemoreceptors, who are going to detect the fact that carbon dioxide is rising within the blood, as well as that oxygen is decreasing and that the pH is shifting. This will cause your ventilation to go up, which, as ventilation goes up, is then going to feed back into your carbon dioxide levels and etc., and hopefully normalize or alter the process, because we're going to be blowing off carbon dioxide and we're actually going to bring those carbon dioxides back down. So again, a negative feedback loop is something that acts in opposition in order to bring balance back to the system. And obviously the opposite is going to be true with hyperventilation. So the next thing we should talk about is lung reflexes. We briefly mentioned that we have an inflation reflex and a deflation reflex. These are your stretch receptors, and these are down in the lungs that essentially just simply sense when your lungs are inflating and stretching. When they reach a certain point of stretching, they're going to say, hey, whoa, we've expanded enough, let's stop at this point. And they're going to send a message back up to the medulla oblongata to terminate or to stop inspiration. This inflation reflex is not something that we operate on so much as adults. It's seen primarily in neonates and is helpful to prevent over-distension of the lungs. The deflation reflex is essentially saying we're using kind of compression receptors that help to kind of deactivate those stretch reflex receptors and say, hey, okay, time to deflate. We also have chest wall reflexes, diaphragmatic, intercostal, and proprioceptors, which are sensing kind of positional sense. So the diaphragmatic nerve, the diaphragm, again, as we said, is innervated by the phrenic nerve, which is very sensitive to movement and to workload forces. So they'll sense changes in rib position and tension across joint spaces, as well as stretching within the skin itself, cutaneous type stimulation. And this increased stimulation of the respiratory muscles is what helps to augment our muscle contraction and our ventilation. Lastly, we have what are called irritant receptors. These are our cough receptors and what is called J receptors. When you see J receptors, you probably are going to want to think asthma. J receptors are little receptors that are very close to the capillaries and the alveolar walls, and they are activated by tissue damage and inflammation, specifically by interleukins. And this is the receptor that actually triggers bronchospasm, which is obviously the classic hallmark of asthma, as well as they're triggered in pulmonary congestion, heart failure, PE, etc. But when we give interleukins such as montelukast or Singulair, essentially what we're doing is we're blocking some of those J receptors and thereby minimizing bronchospasms. Cough receptors are present more in the mucosal linings in the airways and are sensitive to mechanical stimulation. So we have kind of what's called a cough reflex. So that's why sometimes when you start coughing, you really can't stop. You can have a voluntary cough, but when you have to cough, your cough reflex is actually going to override your voluntary control. It is important to recognize that neonates who are less than 35 weeks of age term have a decreased cough reflex, most likely due to poorly myelinated nerves, and therefore are going to be at greater risk of aspiration because they do not have that cough reflex. So when we talk about ventilation and respiration, these two are actually slightly different things. Sometimes we tend to mix up the terms and use them synonymously, but they're not really the same. Ventilation, strictly defined, is movement of gas into and out of the lungs. And respiration is the exchange of those gases of oxygen and carbon dioxide across the membrane. So ventilation is the movement in and out, and respiration is the exchange back and forth across the membrane at the cellular level. This is going to be very important and something you're going to want to know. The point of respiration is to exchange oxygen and to eliminate waste, carbon dioxide. So when we talk about respiration, we're saying we need ventilation and we need gas exchange with it. So we can't have respiration if we have no ventilation whatsoever. But it is possible to have ventilation without having respiration. So there are several factors that affect gas exchange, and this is kind of, you can think of this as ventilation, diffusion, and perfusion. Ventilation, again, is going to be the oxygen content of the air, the patency of the airway. Do you have an obstruction, something that's causing the airway to be obstructed as the air is moving in and out? And that's going to affect ventilation. So things like that might be a foreign body in the lungs. Mucus in the lungs would affect ventilation. A bronchospasm would affect ventilation. Diffusion is the next level. So we've already ventilated, we've gotten our oxygenated air into the lungs. Well, now we need to actually diffuse the gas back and forth across the membrane. So here's our respiration portion. So this is going to be affected by the surface area. How much space do you have available to diffuse the gas back and forth? So if you have a lot of alveoli, then you have a lot of surface area. If you only have a few alveoli available, your surface area is much smaller, which means that you're not going to have as much room for diffusion. Secondly, the thickness of the membrane. The alveolar membrane can become inflamed and thicker, which will actually cut down on or reduce diffusion. So if you have an inflammation of the alveoli or an infection which causes inflammation, such as pneumonia, then you're going to decrease your gas exchange back and forth across the membrane because of the thickness of the membrane. Surfactant and surface tension are another key factor. So those little alveoli are like tiny little air-filled sacs. Think of them as microscopic, not microscopic, but very small little balloons. Something needs to keep those open. And if you don't have enough surfactant, there's going to be a tendency for those little alveoli to collapse and to stick to themselves and not be open. If they collapse, we can't get air in and out. We can't diffuse gas back and forth across the membranes, and therefore we've cut down on our ability for respiration. So surfactant, having sufficient surfactant is very important, but also it's important not to have too much or too sticky or gunky of a surfactant. So if we have a real sticky sort of mucus down in there, once again, those alveoli are going to have a tendency to collapse and to stick to themselves, and then there's going to be less surface area available. Lastly, within diffusion, the concentration gradient and the solubility of the gases affects the movement back and forth across the membrane. If there's a very low concentration of oxygen out in the alveoli, then there's going to be less tendency for that oxygen to diffuse across the alveolar membrane and get into the capillary where it can be transported to other parts of the body. And again, if you have a non-soluble gas, it's not going to want to move across the membrane. Once we've actually gotten to the point where we have diffused our oxygen across the alveolar membrane and we've diffused our carbon dioxide the other way, the next important thing is going to be perfusion. Is we have to have a good and an adequate blood flow through those capillaries in order to bring the carbon dioxide in, get rid of the waste, and to pick up and to carry the oxygen back out on the other side. So if we don't have adequate perfusion, even if we have ventilation and even if we have diffusion, we're not going to be able to pick up the oxygen and get it to the tissues where the oxygen is needed. So there are several factors that affect the mechanics of ventilation. And these are airway resistance, lung compliance, and the opposing forces, which we define as what's called elastic recoil and chest expansion. So these are the big three. Airway resistance is essentially opposition to flow caused by friction. It is the ratio of pressure to the rate of airflow. So if you increase pressure and you increase airflow at the same time, you're actually increasing airway resistance. Airflow is affected by how smooth or how even the surface is that it's going past. So if you have a ridged or a corrugated surface or a surface that has a lot of mucus built up on the inside, you actually have a more turbulent or a chaotic airflow, and you're going to increase airway resistance. It is also affected by airway size. When an airway is smaller, you have greater resistance. This makes a lot of sense. If you blow through a smaller straw, it's harder to push the air through than if you have a bigger straw. And then finally, the viscosity of the gas is going to affect that as well. The second factor is lung compliance. Compliance is essentially the measurement of the elasticity or the elastic properties of the lungs, the ability to kind of expand and contract. If your lungs are not as compliant, then they aren't going to be as flexible and they're not going to be able to expand nearly as well. Compliance in this case is defined as the change in volume divided by the change in pressure. So it's simply a mathematical equation that we're not going to be expecting you to memorize, but just kind of understand that compliance is volume divided by pressure. And then kind of coming down to the fact of elastic recoil. So not only does it need to be able to expand, but it needs to recoil and it needs to come back into place. So recoil is the return or the collapse back to the resting position after it's been stretched. And expansion is obviously the tendency towards outward movement. So elastic recoil is the ability to come back into its natural position after it's been stretched or deformed, which is essentially what we're doing when we're taking deep breaths, is we're stretching and deforming our lungs, and then it is recoiling back into a normal position. So the opposing forces of recoil and expansion are what lead to that negative pressure within the pleural space, which is really and truly critical for our ventilation. And when we lose that negative pressure, we drastically alter our ability to breathe in and out because we don't have that kind of negative pressure going on. And this is what happens in the classic case of a pneumothorax. So when the thorax is not sealed, let's say we've punctured one of the pleural membranes, we now have an open system instead of a closed system. We've lost the negative pressure that keeps that very flimsy lung lining open, and it does what it is now free to do, is it just kind of collapses away, and it fills that space up with air or with fluid. And so the result of that is essentially increased volume within the thorax. So once again, to reiterate, lung compliance is the ease with which you inflate or you stretch your lungs outwards. And recoil is the ability to come back to its normal position. Children, very young infants, have what is considered an almost infinite lung compliance, in that their resting state is very, very close to collapsed, which is a fascinating thing. So they're they have very high lung compliance. And in other diseases, such as pulmonary fibrosis or lung infection, compliance is substantially decreased. So because of the inflammation, we have decreased ability to expand outwards, and therefore we're having poorer mechanics of breathing. So let's take a look at a couple of chest x-rays. This chest x-ray is actually a very classic type of chest x-ray, and the thing that we should note is that there's kind of a little bit of a hazy branching pattern on the right hand side, and we see a small amount of that on the left hand side just opposite of the heart. But then you'll notice that there's a very large clear open space as you move outwards on the left hand side. This is a classic picture of a pneumothorax, and the reason is, if you look near the edge, you'll see here that there's a little edge here of where the lung has shrunk, and it's a little bit bigger than the size of the heart. And then beyond that, that is just pure air out in there. And the reason it looks so dark is that it's the x-rays are passing through it quite nicely, and you're seeing it as clear on the x-ray. There's nothing really there. You would expect to, in a normal and a healthy lung, see a certain degree of kind of this hazy, sort of patchy pattern without any specific areas. But over here, you can see that it's gone. So that's a classic pneumothorax. This picture has a very, very different problem. And initially, you might be tempted to kind of look at the big gastric air bubble and go, oh my gosh, what is that? Well, this is a younger child who's got air in their stomach. But that's not actually the problem in this picture. And so if we look at the right-hand side of the chest x-ray, we kind of see the precordium, the heart there, and then we see a normal sort of hazy pattern without any specific what are called areas of consolidation. And it looks fairly similar on the other side, with maybe a little bit of increased density here. But the thing that's very noticeable is this big solid white object almost dead smack in the middle of the chest. And that is a foreign body in the right bronchus. So if you think about the trachea, which is coming down here, and then it branches into the right, into the left main stem bronchus, well, the right bronchus is a little bit more straight down, and so when kids are inhaling foreign bodies, it's naturally going to fall into the right bronchus. And you're going to pick that up on chest x-ray. So this is a big classic, right in front of you, foreign body on chest x-ray. Again, if we look at this picture, this one is again very, very classic. The left-hand side looks like normal lung tissue with kind of our normal bronchial alveolar type patterns. And then on the right-hand side, it's extremely clear, and we can see this kind of small collapsed line of a collapsed lung. So here it is all shriveled up, and that is our pneumothorax once again. This x-ray here we're taking a look at is extremely hazy, and we'll notice that the diaphragm is shifted upwards here a little bit on this patient, as well as the entire thing is kind of a white hazy look. This is a classic picture of interstitial lung disease in a restrictive pattern. So the lung itself is smaller, it's not going to be able to expand as well. And we can see that there's kind of these fibrotic type changes across the chest. So next we're going to talk about pulmonary circulation, respiration, ventilation, and gas exchange. So when we talk about circulation, we're really talking three different types. We're talking the pulmonary circulation, which is essentially the deoxygenated blood that is coming from your heart. that is essentially responsible for exchanging oxygen and carbon dioxide. Then we also have, on top of that, we have bronchial circulation, and that is oxygenated blood that is actually supplying the structure of your lungs, not specifically involved in gas exchange. So this is actually perfusing the tissues of the lungs. And then we have our cardiovascular circulation, which is oxygenated blood that is going out to our body. When we talk about ventilation and perfusion, you may have heard the terms VQ ratio, or ventilation perfusion ratios. Ventilation, again, is the movement of air, and perfusion is the movement through the pulmonary circulation. So the rate of airflow into and out of the lungs needs to be matched to some extent to the pulmonary circulation, the blood that is coming through. V being our tidal volume, so the volume, and Q being the rate of blood flow in pulmonary circulation, or the perfusion. So normally, perfusion is going to be a little bit more than ventilation, and this means that we're being efficient. We're actually perfusing a little bit better than our need for ventilation. So the pictures that we have on the right-hand side are looking at a couple of little alveoli, and you can see that on one side we have the top picture is a low ventilation perfusion versus the other side, which is a high ventilation perfusion ratio. So we can essentially, what we're having is we're having a mismatch in either there is more ventilation than there is perfusion, so we're not getting enough blood flow there, or we have less perfusion than we need to actually pick up the gas that is being brought in. So we can have a ventilation perfusion mismatch. Ventilation perfusion ratios, a normal ratio is essentially 4 liters per minute of alveolar ventilation matched by 5 liters per minute of blood flow. And again, you want your blood flow a little bit higher than your ventilation so that you have some, you're being really efficient in that you're coming by and you're picking everything up. If you have a low ventilation perfusion ratio, then you might have a 2 liter per minute of alveolar ventilation, meaning that the airflow in and out is low, but your blood flow is still pretty good. You still got 5 liters per minute coming past, trying to pick up the gases that are being exchanged. So in this case, you have an underventilated patient who still has pretty good perfusion. So this is something that could happen in mechanical ventilation, or it could happen in respiratory distress where you're still pumping pretty good, but you're not getting air in and out as well as you should. It can happen in early stages of respiratory rest. High VQ ratio where you're underperfused, meaning that you're actually moving the air in and out well, but you have got very poor blood flow coming past. So we might think something like a pulmonary embolism. Something's blocking the area and we're just not getting enough blood flow through. In terms of oxygen and carbon dioxide transport, the majority of oxygen, as we mentioned previously, is going to be transported by hemoglobin. So it is bound to iron receptors on the hemoglobin, and it is transported from the alveolar, from the capillaries just outside the alveoli to the tissues where we need oxygen. Carbon dioxide, about 5 to 10% of it is just free floating in the plasma, which is part of why it really does affect our pH. And then 60 to 70% of it is actually bound into bicarbonate. So our body says essentially it can tolerate a certain amount of carbon dioxide floating around, but when the carbon dioxide levels start to rise, then it's going to start converting it into bicarbonate for transport so that we don't affect our pH levels too much. So you may have heard the terms right shift and left shift. Essentially what we're saying that as carbon dioxide levels go up, our pH level is going down, that's a right shift, and left shift is the opposite end of the spectrum. As our carbon dioxide levels go down, our pH is going up. The thing that is important about this is that as pH goes down, our oxygen binding capacity goes down, which means that our oxygen is more likely to dissociate. So if you think that carbon dioxide is essentially going to be higher in the tissues, where we're engaging in metabolism, so it's a byproduct of metabolism, then our pH is going to be lower in our tissues than it is closer to the lungs. In which case, oxygen binding goes down, which means it triggers our hemoglobin, our red blood cells, to release or to dissociate from the oxygen and to let go of the oxygen. So our body has to know when to pick up the oxygen and when do you let go of it. So as pH goes down near the tissues where there's more carbon dioxide, we let go of oxygen. Once we get back towards the lungs, the pH is going up. We're becoming more basic and we're increasing our oxygen binding affinity because there's less carbon dioxide. And so therefore we're going to want to grab and pick up the oxygen that is diffusing across the alveolar membrane into the capillaries. Carbon dioxide plus water essentially is equal to carbonic acid. This little formula here is just showing you the process of how we combine carbon dioxide with water and how we end up with hydrogen ions and bicarbonate. The intermediary is this carbonic anhydrase, carbonic acid, H2CO3. This further dissociates into hydrogen ions and into our bicarbonate, which is what we're typically measuring when we're measuring pH and when we're measuring bicarbonate levels on our lab. So when we're measuring to see if a patient is acidotic or alkalotic, we say, oh, what's their bicarb level? What's their hydrogen level? And what's their anion gap? Because the anions are going to also try and compensate for our pH levels. So these all help us to know what's going on both from a respiratory standpoint but also from a metabolic standpoint. So the dissociation of carbonic acid into hydrogen and bicarbonate is happening fairly slowly within the plasma but fairly quickly within the red blood cells. The bicarbonate ion diffuses out into the plasma quite easily, but hydrogen does not. So in order to maintain kind of the electrical neutrality that we've been talking about with our cells, the cell is going to bring chloride ions inside the red blood cell as the bicarb is diffusing out. So this is what works together in order to create our kind of oxygen hemoglobin dissociation curve, like where does everything associate and dissociate. And really the take-home message is as the tissues become progressively more acidic, as we have more buildup of byproducts from metabolism, the oxygen bond between hemoglobin and oxygen is going to get weaker, and we're going to dissociate our oxygen and we're going to let it go. Again, this is just another picture showing right shift versus left shift and what is known as the oxygen hemoglobin dissociation curve. You don't need to memorize this specifically, but just know that this is out there and this is a classic term. That as our pH goes down, oxygen binding goes down, we dissociate more freely. As pH goes up, oxygen binding binds more tightly and we're less likely to let go of our oxygen.